My core belief is that the precision medicine revolution is going to be driven by tools and diagnostics, so by the technologies as opposed to the drugs. And the reason for it, or like the rationale, is that if you look for the prognosis for cancer patients, it is actually tied to stage of diagnosis as opposed to the therapy that they go under. If you catch cancer at stage one, and it doesn't matter which, you go to the hospital with surgery, they just remove it and you're going to be fine, most likely. If you catch it at stage four, this is when you really are in trouble. So that's really no matter what therapies you go under. So this is really why I saw the benefits of these technologies that can really transform this sick care model that we are in right now into a much more proactive healthcare model that to help you stay healthy and catch disease earlier. But the reality check is that many patients still do not receive the guideline recommended testing, even though these tests are available and they are reimbursed. If you look at cancer in general, the stats are like way lower than this, and it's maybe only a third of advanced cancer patients that get testing in the US right now. So there is this huge opportunity to increase testing, increase awareness, and also making sure that patients actually take care in their own hands. If you do a bit of research right now with all of the tools available, you can really try to advocate for yourself.
This is Genetics for Healthcare, a podcast for patients.
Welcome to another episode of Genetics for Healthcare, podcast dedicated for patients and their caregivers, their loved one, to help advocate for a precision medicine approach to their healthcare, which includes disease screening, prevention, treatment, and survivorship. Be sure to go to our website, geneticsforhealthcare.com. And while you're there, hit that subscribe button, especially on YouTube, so you can get updates on amazing new content and episodes like this one. Today, I'm happy to have a conversation with Mr. Stefan Boudel, the founding partner of DeciBio, who is very much helps the industry bring new products to the market in this area of precision medicine and NGS, next generation sequencing diagnostic tools to help us get excited about what's coming and what they see on the horizon in precision medicine this year. Stefan, thank you so much for taking a little time to talk to us on Genetics for Healthcare.
Of course, it's my pleasure to be here.
So talk about DeciBio. What is the company? What's been your background and what kind of got you into the work that you guys do?
Sure. So DeciBio is a strategy consulting firm focused on precision medicine. And we tend to work a lot, as you said, with companies within the life science tools space. So the one that actually generates or make the instruments that are being used by scientists or by doctors in order to make diagnostic tests. We actually also have a fund, which is interesting. It's pretty unique in the sense that we also invest in the space. And as far as my background goes, I really sit at the intersection of business and science. I'm from Geneva, Switzerland, so that's where the accent is from, and came to the US to do a PhD in neuroscience. Was one of the first user of that technology, next-gen sequencing. And this is how I fell in love with precision medicine when I saw the promise of what this could do, not only for scientists, but also for patients.
So what made you want to start a firm? And I guess going back a couple of decades that I've been involved in this industry that we call precision medicine, 10 years before NGS was a fresh tissue assay, right? Where you had to harvest them at the time of surgery. You had to procure the tissue a certain kind of way to get any information on what's most likely or least likely to benefit a patient, right? So we know that the technology has, my gosh, improved 100-fold, but we're still asking the same questions. Is how do we identify the patients who are most likely or least likely to benefit? And we're having challenges with the uptake and adoption and reimbursement. But why did you conceptualize the need for your firm, and what problems did you want to solve in the market?
Yeah, so the problem we wanted to solve is interesting. That I've seen the technologies in the lab, and they are actually quite remarkable. But there is a big difference between scientists in a lab using a technology, and as you said, this technology actually benefiting patients. Right. And so the goal or the aim for DeciBio and the reason why we founded the firm was really to try to accelerate the adoption of these technologies of precision medicine. And I think the idea was, at least like my core belief is that the precision medicine revolution is going to be driven by tools and diagnostics, so by the technologies as opposed to the drugs. And the reason for it, or like the rationale, is that if you look for the prognosis for a cancer patient, it is actually tied to stage of diagnosis as opposed to the therapy that they go under. If you catch cancer at stage 1, and it doesn't matter which, you go to the hospital with surgery, they just remove it and you're going to be fine, most likely. If you catch it at stage 4, this is when you really are in trouble. So that's really no matter what therapies you go under. So this is really why I saw the benefits of these technologies that can really transform this sick care model that we are in right now into a much more proactive healthcare model that to help you stay healthy and catch disease earlier.
Okay, so you're speaking my language. I'm really excited that you said that. Okay, so let's talk about the state of adoption. NGS testing has been available in different facets, because when we say NGS testing, I mean it is a type of way to sequence genes to get information for treatment and other things. So that represents many different types of tests that will give genetic or genomic insights to be able to make these healthcare decisions. But what do the latest stats say about biomarker test adoption in oncology? And that's a broad question, but I want you to hit it with a broad stroke.
Sure. So I think that the good news is that the adoption is way better than it was a decade ago, especially in lung cancer and some other frontline cancers, if you will. It's now really standard of care, and it's no longer some kind of exotic test that people would order. But the reality check is that many patients still do not receive the guideline recommended testing, even though these tests are available and they are reimbursed. So in the US, I would say that the most advanced in lung cancer, you probably have something like 80% adherence and to get a biomarker test, somewhere between 80 to 90%, depending on the stats that you look at. And people test for these usual suspects. Some of the names of the genes that some patients may have heard about are EGFR or PDL1. But if you look at cancer in general, the stats are like way lower than this. And it's maybe only a third of advanced cancer patients that get testing in the US right now. So there is this huge opportunity to increase testing, increase awareness, and also making sure that patients actually take care in their own hands. If you do a bit of research right now with all of the tools available, you can really try to advocate for yourself.
Can you talk about when we say NGS testing, right? Are there any NGS use cases that are more frequently used in patients who have cancer? I know you just mentioned lung cancer, where we see it being standard of care, and it's made some real impact on outcomes, like extending patient survival. 10 plus years ago, the diagnosis of non-small cell lung cancer, statistically, 50% of those people passed away within 12 months. But now we're seeing, and talking to different clinicians, they're seeing, this information, using this information in a timely fashion, extend that survival with people with stable disease. They're not necessarily disease-free, but they're able to maintain a good quality of life because they're able to stay on the medication, that these targeted medications. So if we look at the span of NGS tests that are in the marketplace, you got germline genetic testing, which we talk a lot about on this podcast, comprehensive genomic profiling, which is kind of a mouthful, but we want folks who listen to this to know these terms: liquid biopsy, solid tumor analysis. In the world of NGS tests, what is more frequently used, and what are some things that people listening to this need to watch out for in terms of the words when they're used?
Right. So let's start with a few definitions. I think you're right that it would be helpful for your listeners. So if you are a healthy patient, you could actually get a test in order to understand what are the odds that you're going to be developing cancer. And this type of tests are based on your germline or the DNA that you've been given at birth. And it is essentially called a hereditary cancer test. It tests, like most notably, I think Angelina Jolie made that test famous with BRCA testing, where she realized that she was at risk, and then she had a mastectomy based on the result of that test, because she knows that she was at risk for breast cancer. So that's germline testing. Now, if you think about the entire patient journey, which is a bit of an ironic term to use because it's only a journey that the patients want to be on. But you can actually do an early cancer detection test. Once you have a diagnosis of cancer, there is a variety of tests that you can test that you can take. One is just do a biopsy of the cancer and test the tissue. And you're right that either you can try to do a very focused assay, even looking at maybe one gene, like EGFR, for example, and using PCR. You can do a small panel using next-gen sequencing. You're going to be testing maybe for a dozen genes, maybe for 50 genes. And people refer to that as a small NGS panel. And as you said, there is this comprehensive genome profiling test, CGP, that tests now typically for around 500 genes. And so that gives doctors a lot of therapeutic options in order to how to best target the type of cancers that you have. Interestingly enough, there is a company called Caris now that went even beyond that and actually would sequence all of the genes that your body actually expresses using whole exome sequencing. So they target about 1% to 2% of your genome. So all of these tests are being done on the tumor itself when you take a biopsy, right? Now, in addition, you mentioned liquid biopsies, and you're right that if for some reason your tumor is very close to a blood vessel or you're pretty frail and you cannot do a biopsy, you can actually just do a blood draw. And as it turns out, the tumor actually sheds DNA into the bloodstream. And as a result, you can actually sequence that DNA from the blood, identify it's come from the tumor, and try to find what are the mutations that are present there. So those are essentially somatic tests, and somatic as in you actually sequence the tumor itself. Now, to make things even more complicated, there is a new battery of tests that you can do to help manage the patient as that patient is getting treated. And so these tests are being referred to as monitoring tests or sometimes MRD tests for minimal residual disease. And you can actually use these tests in a variety of different stages within the cancer patient journey, either before you give a therapy, so it's called neoadjuvant settings. You can test it after the therapy, so it's adjuvant testing. You can also try to use this test for surveillance, try to see if your cancer is coming back as an alternative to imaging with the MRI. So there is a number of tests and NGS tests that you can do right now. And a lot of them are gaining traction because, again, it gives doctors more therapeutic options in order to treat the cancer the best it can be.
I appreciate you for unloading those terms. And for those listening, if you go to genetics4healthcare.com, we are going to have a glossary of terms that you can go in and learn these terms to be able to have these conversations with your care provider and your family members to become a more effective advocate. Because as Stefan just mentioned, we really want to empower, because of the gap in adoption, people to go in and advocate and understand what these terms mean and bring them to their doctors to have conversation on shared decision making.
Yeah, this is a great resource. And I think that the second question that you asked was around what was the level of use of these tests, right? And the relative use of these tests. And right now, I would say that the majority of tests are still being done on the actual tumor itself, but this liquid biopsy are gaining traction really rapidly. And so to stay on top of this, I think is important because, again, it offers a lot of options for managing care.
So you mentioned care delivery, and we try to give an inside view with sharing a patient-first lens on these topics, Stefan. And when you're going through the process, a lot of times the experts that you're going to meet with, from a surgeon to an oncologist to a radiologist, any number of providers, do these tests get ordered? So I guess the question is, along with improved NGS test adoption in lung cancer, where have you seen the most meaningful progress in terms of care delivery in the last 2 to 3 years?
So it's interesting. In terms of care delivery, we can answer that question from a number of different angles. The first one is actually, even zooming out quite a bit, there is this massive expansion in terms of geographies. This is a type of test that really started in the United States, and that now we see much broader adoption in Europe and all around the world. But if we were to focus within the United States, we've seen increased adoption within different cancer stage. So it used to be only for advanced cancer, and now you have earlier and earlier adoption in case of not only stage 4, but stage 3 or 2B. You start to see more and more uptake of these tests earlier in a patient journey. There is also more adoption of these CGP tests as opposed to these small panels. So the goal is you test more patients, and on each of these patients, you're going to try to get more data. The beauty of that, and we can talk about it some more, is that as you get more information, not only is it better for the patient, but it's also better for the healthcare system. The more information we have, the more we can actually improve the algorithm that power this test and actually improve the care for future cancer patients. And then the adoption that we see growing actually quite a bit right now, as I mentioned, is in liquid biopsies. So not only like taking this test on the tumor itself, but actually when you can't biopsy the tumor, doing the test, using a blood sample, and actually tracking that along the entire patient journey.
How has reimbursement from CMS or other private payers helping drive the adoption? Have we seen the reimbursement landscape get better, as well as the guidelines, the endorsement from different medical societies?
Yeah, it's both are improving actually quite a bit, and the reimbursement was one of the key factor actually gating adoption of this test historically, and we see the reimbursement improve quite a bit. And so there is actually two ways to think about reimbursement. The first one is what percent of the time are you going to get paid, and the second one is what percent of the list price of the test is it getting paid. And when you look at what vendors refer to as the ASP, which is the average selling price, it keeps trending up and up and up, because the good news is that many of these vendors will run the test regardless of whether it's going to get reimbursed, and they're going to actually just fight for reimbursement afterwards. And so as there is increased inclusion in guideline, it gets easier and easier for this test to actually get reimbursed. And as you mentioned, the inclusion in guideline is critical because 70 to 80% of cancer patients are actually treated in more rural or let's say not more community type settings, and these doctors tend to actually be referring to this guideline more religiously, let's say, to these academic medical centers who can be more creative trying to include patients in clinical trials.
When you talk about the 80% of patients being treated in the community setting as opposed to the academic medical centers, that the well-known names that we'll know, like the Mayo Clinics, the MD Andersons, who are the centers for the research and innovations that are coming out in healthcare. The one thing that hinders is the workflow, right? Because you don't have the same number of experts in a whole hospital system dedicated to treating cancer, and a whole division with staff dedicated to treating one type of cancer. These doctors in the community setting are going to treat every patient that walks through the door, and it can be really difficult to keep up with all of these innovations, all the new findings, the indications of these tests. What needs to happen for today's clinical workflow to accommodate and scale the practice of precision medicine in oncology?
Yeah, I love that question. This is a really great one, Rome. And I think that if you want precision medicine at scale, you just cannot rely on heroics from one enthusiastic oncologist at an academic medical center, right? You have to really bake it into the workflow in a way that it is standard of care that everybody actually can easily follow. And what that means is reflex testing, for example, where the lab automatically runs the right panel when a certain cancer is diagnosed, right? Instead of, you don't want to have to wait for a special order. It also means that the reports have to be extremely clear and land directly into the EMR, like the electronic medical record, with a simple this is what it means for the actual treatment of that patient. And this is what actually needs to get done for the patient. And it also means some kind of team-based model where oncologists and pathologists and genetic counselor can all get aligned, so that the patient the patient or the oncologist doesn't have to stitch that story together, themselves. So there is a lot that needs to happen, but it is really starting to happen more and more. And this reporting, I think, we cannot understate how important reporting is. The fact that ultimately, once you have the test results, you need to know exactly what it means and how you can manage that patient.
Yeah, absolutely. Stefan, AI is everywhere.
Yep.
I don't even know how to even prepare for your answer for this question, but how do you think AI solutions are going to impact adoptions? I mean, how many different ways can it impact?
Yeah, it's you're right that it's like this AI is gonna be all over the place, and it's gonna impact adoption in a number of different ways. I don't think it's gonna replace oncologists, but it can certainly help them make the right decision. AI can help with imaging software, trying to whenever you see a picture, like trying to understand, well, what does that mean for the aggressiveness of this disease, for example. Is going to be able to help also analyze what are like the genetic signatures of this patient and what that means in terms of the type of cocktails and the sequencing, like no pun intended, of the therapies that the patients are going to have to go under. Is going to also really help us understand and better understand the biology of cancer. And again, once we understand the biology, that means better targets, and that means more therapeutic options, because it is really a war. And finally, it's going to help also, as we discussed, with just simply workflow and making sure that everything actually happens seamlessly, as opposed to getting caught in some time of red tape. So it's going to be really transformative. I'm extremely bullish on AI, not only within healthcare but across the board. We're going to have to make sure that we actually implement it in a way that is equitable, that is really thoughtful, but it can be very transformative.
I've been working on this challenge associated with scale and access to precision medicine for quite a while, and whether it's building teams or now building SaaS solutions to help streamline that process. The At the end of the day, it's about the patient. It's about the impact on the patient, not only from a timely treatment and to get the most optimized treatment, but also from a financial impact, if we can say that. So how has the increased adoption of these NGS tests and tools, or the lack of adoption, impacted outcomes from a survival or an improvement in treatment outcome standpoint, or financial?
Yeah, so for the patient, it's undoubtedly improved outcome, but it is actually really hard to trace and track it, as it turns out. There is a lot of variables involved, but I think that, as I mentioned earlier, you can talk to any oncologist and they will mention that prognosis and the stage of diagnosis matters so much. And making sure that you can get a therapeutic option quickly actually is going to matter for the patients. I think there is this perception also that, well, now these tests are getting increasingly complex. So as a result, it's going to explode the healthcare budget, which is already so high. But the reality, and it is a contrarian view that I have, is that if you want to save on healthcare costs, you actually have to increase the cost of diagnostics and increase the number of diagnostic tests that are being run. And the reason is that right now a lot of the diagnostic companies are actually running on very thin margins. A lot of them are actually not profitable. They're losing money. And if we continue to actually invest in innovation, you can actually improve the care of this patient and treat this patient sooner when it's actually much more affordable. Because ultimately, the real cost of care comes down to hospitalization and the therapeutics themselves, as opposed to the diagnostic test. The diagnostic test can really help you save costs outside of the of only this diagnostic bubble, but really in terms of the overall care of the patient. So I'm very bullish on the need for investment in diagnostic, because, as I said, I do believe that treating patients when they're still healthy and before they really get sick is much more affordable than waiting until it's too late.
Okay, I got to double click on that. So, the model over the past few years for diagnostics and bringing diagnostic tools to the market, it was kind of set up to for, I won't say failure, but the thin margins. I mean, you had to a company had to put the diagnostic in the market to show payers that there's demand for this product, and then go and try to negotiate a reimbursement based on that. And that's not necessarily changed. It doesn't make sense to me that you have a $300,000 therapy that you would pay for a cancer patient, but you won't pay $3,000 for the diagnostic to identify whether that patient is likely to respond to it or not.
Mhm.
Okay, just me. But from an investment and from an industry health standpoint, we're now starting to see consolidation of very large companies, buying successful diagnostic companies. What impact do you think that's going to be on the longevity and, as you mentioned, the investment to increase our perceived value of diagnostics?
Yeah, so it's interesting. I'm of two minds on this one. So I do see, for example, like most recently, you're probably referring to the fact that Abbott, who is a very large diagnostic company, acquired Exact for 23 billion, and this is actually the largest diagnostic deal in history. And the beauty of that deal, I think, is that Abbott has like the international channel, so they can really help push that test, not only in the US, but also abroad. And so this is a big win for colorectal cancer screening. And I think that it really moves the needle in the right direction. Now, the danger whenever you have a large company buying a more innovative company is always that they try to milk it in some sense. And they're going to try to, take that test and push it as hard as they can to get as much cash as they can, as opposed to reinvest that money for more innovation to actually develop better tests for maybe going after different cancer types or increase the sensitivity of these tests. So I think overall, this type of activity is good for the industry. We actually do need this type of M&A. It leaves room now that Exact is not an acquirable asset anymore for other companies actually to get acquired, including earlier stage companies. And actually, you can see that a lot of the stock of other labs similar to Exact actually popped when the news that Exact got acquired, because people started to think like, well, that means that there is some attractiveness there. And again, this type of financing is critical because up until this year, like in the last 3 years, a lot of investors thought that diagnostic tests are just uninvestable. They're like, we can't invest in that space because there is no way to make money. And it's like, ultimately, as an investor, I need to put my money somewhere where I feel like I'm taking a risk and I want to get the return. And so I think that 2025 was actually a decent year for diagnostics. Another company called Garden Health, so its stock go up close to 200%, I believe. Haven't checked the latest number. So this type of activity is overall actually quite healthy and necessary. It's one of the dark side. That's no, we don't only do this to help patients, but also what fuels this is in some sense greed and the willingness for some of these companies to be buying this at a premium.
That was awesome. I really, really appreciate that insight, by the way. I'm on record for sounding the alarm, and I've done it on my podcast. I've done it on other webinars that we talk about the future of precision medicine. And I'm of the mindset when we talk about disparities, the promise of precision medicine is that we can eliminate disparities. If we can systemize patients getting the appropriate tests that inform, downstream care and optimize the right medications at the right time for the right patient, we can really make a dent in health care inequity and outcomes. But on the flip side of that, it can also exacerbate that disparities gap because the medicines of tomorrow will be optimized to those patients who are getting profiled and participating in clinical trials. Does DeciBio look into that sort of perspective when it comes to biomarker testing and disparities that could possibly show up?
Yes, we do, and I'm glad that you've been a key voice here, actually, like shedding a light on the fact that these disparities actually continue to exist. And you're right that there is always a risk whenever you have one of these disruptive technology that tend to be priced a bit as a premium compared to what exists currently, that is going to actually exacerbate some of these disparities. So I do believe that ultimately, in a long term, it's actually going to be improving the life for everyone. I mean, if you look at the way that a cancer patient, even in the most rural setting in the US, is being treated today versus a billionaire 20 years ago, like the standard of care has still actually improved quite a bit for someone in a rural setting right now. So the goal is obviously to compress that gap and to ultimately eliminate it for everyone to actually get access to the best care. I think that you're right that in the short term, I'm afraid that unless there is very conscious investment and focus on it, this disparity is going to continue to is essentially going to increase. But obviously, the goal, as I mentioned, is that as AI actually gain traction and it become like easier and easier to actually identify what is the best care for each of these patients, that gap should actually shrink again. So it's my prediction is that in the short term, you're going to be always better off if you're like the top 1 or 10% of payers within the healthcare system in the US. But in the long term, this gap is actually going to shrink.
So I got to dig into this too. So you just mentioned payers. So CMS, which is your Medicare patients, they do reimburse, fairly well for a lot of these tests that we're talking about as it pertains to cancer care specifically. But self-insured employers, and I just know enough to be dangerous. I don't know this, and I ask this question. I don't know if it's relevant. Please tell me if it is. So from a policy standpoint for self-insured employers who are now becoming more aware of, hey, we may need to think about making these tests covered in our plan, especially for our members, because we know that can keep them on the job, keep them healthy, improve quality of life. How can self-insured employers benefit from the adoption of precision medicine in policies?
Yeah, so for self-insured employer, cancer is one of the biggest cost driver and one of the most emotional topic in their workforce. So precision medicine offers a way to spend those dollars like more intelligently in some sense, and more on the test and drug that actually fits the biology of the tumor, and less on cycle of trials and error. So that can translate into fewer hospital day stay, less side effects, people actually feeling better about their work and life. And ultimately, I think the reason why these employers do it is both as a benefit to their employees in order to show that they actually care about their health, but also because they think that they're going to have the reward in the form of like they're more healthy employees actually doing better and spending more days on the job. I'm sad to report this is not something that is very common. I think it's still a pretty small fraction of these self-insured employers that actually have a system like that. Even at DeciBio, I think we have like really good healthcare system, but we don't have this self-insured model. This is still something that is reserved to, I think, many of the large firms or biotechs in the tech area, in the Bay Area.
Yeah, I appreciate you asking that question because we do have a wide audience that subscribe, which I'm very grateful for all of our listeners, by the way. But we do have payers. We do have those who are industry professionals that will listen to this podcast. So I'm going to ask you this because we have you on the show. I got to ask you this question. I mean, it's beginning 2026. I mean, as you look forward, and what excites you about the industry? Like what's coming, what, movers and shakers, deals, whatever it is, what has got you and the folks at DeciBio excited about precision medicine 2026?
Yeah, a lot. I think that's the easy answer is AI. So I'm not gonna give you that answer because I think it's in some sense too easy or too obvious. I will tell you the second thing that I'm very excited about is multiomics. So right now we talk a lot about the fact that you can do this next gen sequencing test in order to understand the genetics of the tumors, right? The DNA, the ATGCs, right? Now, as it turns out, the DNA actually is translated into RNA, right? And RNA is then used to make proteins. And so there is more and more of these tests that actually assess DNA, RNA, and now increasingly actually folding in proteins as well. The reason why that matters is because protein is ultimately what does the job in a cell, right? And this is really what makes you sick is not the DNA, is the protein that DNA makes. So it's actually closer to the phenotype is another way to say it. So we have more and more of these very rich multi-omics data sets that look at DNA, RNA, and protein, and then some. And AI, again, is going to help us make sense of this very complex data set. I think this is going to be very transformative for the care of patients. I do believe that these different layers of biologies are different set of insights. And again, AI will help us make sense of this because it's going to have a level of complexity that is just unimaginable.
It's phenomenal. Phenomenal. Stefan, I really appreciate your time. I will tell you that, at the end of the day, we want these conversations to be empowering and not intimidating to people who need to know this information, which are many times decidedly non-medical people, someone who just received a diagnosis, a cancer diagnosis. And I love to ask our guests for practical tips for someone who's watching this, because it's usually, when this impacts, someone in your family, or it impacts you firsthand, and it impacts a family, it impacts your loved ones that are around you. And we like to give them, empowering tips, information, even though this is not a medical advice show, obviously. But for patients, for someone who might be watching this and is experiencing a cancer diagnosis or has a history of cancer, what are three practical tips that you can offer them to help them advocate for themselves to ensure they're getting access to these life-saving diagnostic tests?
Right. So I think like a very simple question to ask, like to begin with, is just simply asking your doctor or your care team, like, has my cancer been tested for genetic or other biomarkers that could change which treatment you would recommend to me? The second question would be which test did you run? And what did they show? What are the results? Are there any biomarker that have not been tested that actually may matter? Does it make sense to go, if a small panel was done, to not one of these complete genomic profiling tests? And if we have not done this test, is there a reason why we have not? And try to encourage people to ask to see the pathology report in some sense. And again, there is a lot you can do right now with AI to help you, understand if there is, for example, some specific programs and clinical trials that you could enter. At maybe, as you said, the Mayo, MD Anderson, Moffitt. There are a lot of very elite institutions that can help in a case where your cancer is, more atypical, let's say. The reality is that the quality of your care that you get in community settings right now in the US is actually extremely high because of this, the standard of care, etc. And a lot of time when there is a bit of a divergence in terms of, what are we supposed to do here? These community settings are really good about going to academic medical centers that can help actually with some kind of program, and then they can actually execute it. With that being said, I'll be perfectly honest that if I were to get a diagnosis of cancer, I would probably try to go into a large city and get the care that I can at one of these academic medical center. If you can, again, it's not always possible. For some reason, people may have to stay where they are. And if that's the case, I would say, again, the encouraging thing is that the care in community settings in the US has gotten actually extremely good.
Stefan Boudel, founding partner of DeciBio, getting me all excited about the future of precision medicine and helping us understand the world of biomarkers, genetics, and genomics. Stefan, thank you so much for coming on and sharing your knowledge and wisdom of the industry with our audience here on Genetics for Healthcare.
Thank you very much, Rome. And I will say maybe one last thing. Like, thank you very much for the work that you do. I think it's extremely important. I'll tell you one last final story that we had an employee leave the company recently, and I asked her for feedback about like, how is it that I could do better? And she told me something that like punched me right in the gut. She said, I feel like sometimes you care about innovation and the technology more than you care about the impact that it can really have on patients, and you lose sight of that. And that was an amazing reminder that this is not only about the technology, it's really about improving care. So I'm very glad that you do what you do, because I think that you can really help these patients really access this technology. So thank you for that.
And I appreciate that comment. We won't stop. We have a definite purpose of doing just that.
Perfect. Thank you, Rome.
This is Genetics for Healthcare, a podcast for patients.
Quality of the AI generated pictures that you can have, it makes you look really good. So maybe that's what I use.
I get sucked into social media and these apps. And so I did this, and it was like an app that's called like Insta Headshot or Insta whatever it was. And, you get over about, 100, 120 headshots. And quite honestly, they're amazing. they look pretty good.
It is complete insanity. I was just at my in-laws for over Thanksgiving. I want to show you this because my father-in-law is a huge fan of Steph Curry. And so I generated, and he likes Joe Biden as well. So I generated this picture for him of him shaking the hand of Steph Curry. It's like the happiest I've ever seen him. Even at a wedding, he wasn't that happy.
That's pretty good.